So good afternoon, all of you. I am Dr. Deepak Tambe and my colleague Dr. Aditya Pawaskar. And now we'll keep it very short and sweet, that meniscus preservation by all the eminent faculties in the WIROC MAX 2022. And we have kept it so short that it will be 6 to 7 minutes of talk followed by your question and answer session immediately. So I would like to chair this session. May I like to invite Dr. Aditya Gunjotikar to please chair this session. He is an eminent arthroscopy surgeon from the city of Mumbai. And Dr. Parth Agarwal, he is also an eminent arthroscopy surgeon. They will be chairing this session. And my colleague, Dr. Aditya Pawaskar, please have a seat there. So we'll start with the first talk, that is the patterns of the meniscus tear and MRI analysis of the same. Dr. Ajinkya will be delivering this talk and it will be followed by question and answer session immediately. Dr. Ajinkya, please.
So the topic is the patterns of meniscus tear and the MRI analysis. So what are the learning objectives of this particular talk? So you will understand the pertinent anatomy and the blood supply of the meniscus. You will be able to classify the meniscus tear patterns. You will be able to read the MRI films for various meniscal signals and interpret them. And you can also correlate the MRI and the arthroscopic findings of the meniscus tear. So first I will start with the anatomy part. So meniscus is the word originated from the word crescent. So meniscus is crescent shaped and on transverse section, cross section it is triangular. You can see the posterior horn of the medial meniscus is broader as compared to the anterior horn, while in case of lateral meniscus, the anterior horn and the posterior horn both are almost of the same width. This is the particular very important anatomy where you can see the anterior root and the posterior root. Particularly this one is the anterior horn and the posterior horn, and in between anterior horn and the posterior horn is the body. For the same, these are the roots. This is the intermeniscal ligament which you can see in the anterior region. Then the most important is the blood supply of the meniscus. As you can see in this picture, the blood supply mainly comes from the periphery. So the perimeniscal capillary plexus gives blood supply from periphery to the inner free edge. So the maximum blood supply is at the edge. So this is the again representation of how these zones are divided according to the blood supply. So zones can be from the free edge, it is the white zone. In between the red-white zone and on the periphery is the red-red zone. So you can see the particular tears which are in this region of red-red and the red-white zones have a good supply, and so these tears are amenable for repair. Then we go ahead with the ultrastructure of the meniscus. In order to discuss the patterns of the meniscus tear, it is very important to know how the meniscus is formed. So you can see at the periphery, the circumferential fibers are there, and in between the free edge and the periphery are the radial fibers along with few perforating middle fibers. Then comes the important part, that is the imaging. So MRI is the critical tool for clinical decision making and the surgical planning. Meniscus tears are well visualized on MRI on the coronal and sagittal sequences. Sagittal plane, both anterior and posterior horn of the meniscus are visualized. So that one is the coronal view of the particular meniscus of the particular knee joint, and this is the sagittal view. This is the fat suppressed T2 weighted image. You must have seen that on the MRI reporting there are various signals they have mentioned, that is the grade 1, grade 2. So what exactly are these grade 1 and grade 2 signals? You can see the grade 0 is the signal, you will not be able to see any signal. On the grade 2, in the grade 1 there will be a particular the intrasubstance globular signal without extension into the articular surface. Then comes the linear increased signal, that is the grade 2 without extension to the articular surface, and comes the grade 3 where the articular surface is involved. Now we go ahead with the main topic, that is the classification of the meniscus tear. As you can see, these are the particular important meniscus tears which we come across in our routine practice. First is the vertical longitudinal tear. So the vertical longitudinal tears, these are the tears between the circumferential fibers of the meniscus. These tears are particularly parallel to the long axis of the meniscus. Means this is the particular circumferential fibers, and these tears extend on the parallels of these circumferential fibers. On MRI, you will be able to see this kind of a vertical signal on the sagittal images. Also, on the axial cuts, you will be able to see the particular linear impression. Then comes the bucket handle tears. This is just the extension of the vertical longitudinal tear, and most of the time it is get displaced. So you can see this is the double PCL sign, which is very classical of bucket handle tear of the middle meniscus. Also you can see on the coronal section, this is the displaced middle meniscus. This is the arthroscopic image of the bucket handle tear. Then comes the radial tears. In radial tears, you can see the particular tear pattern is perpendicular to the circumferential fibers. This is the particular radial tear. And this is how the marching cleft sign is present, where you can see there is a cleft between the meniscus. Then comes the parrot beak tears. Parrot beak tears are nothing but the radial tears which are not extending into the particular periphery. You can see this is just like a parrot beak. Then comes the horizontal cleavage tear, where the meniscus is particularly the free edge and it propagates to the periphery. On MRI, you will be able to see this particular cleavage, and this is the particular meniscal cyst which forms after the synovial fluid gets sipped through the horizontal cleavage tear. Then comes the meniscus root tears. Three most cardinal signs are the ghost meniscus sign, the truncation sign, where you can see the linear vertical impression on the posterior aspect of the knee joint on the coronal sections. And then comes the extrusion of the meniscus, where the extrusion more than 3 mm is significant. This is how the meniscus root tear appears on an arthroscopy image. Also you can see the same correlation on the MRI. Then comes the ramp tear. So particularly this Strobel introduced the term called the ramp tear. This is just a meniscocapsular separation. You can see this is the meniscus, and particularly the capsule is attached to that meniscus. This is for the particularly important for the middle meniscus. On MRI, you will see a particular signal between the posterior horn of the middle meniscus and the posteromedial capsule on sagittal images. On posteromedial portal view, you can see this particular separation of this is the meniscus and this is the capsule. This is particularly the ramp lesion. Then last comes the complex tears, where more than 2 patterns are involved. That is the longitudinal tear, the radial tear. Here the appearance is fragmented. Also you can see arthroscopic correlation that the particular meniscus is frayed and all the patterns are involved. Here you can see the bucket handle component is there, radial component is also there. So in short, we have seen all the meniscus patterns and tears, how they tear. So my take home message is, after clinical examination, don't rush to see the MRI report. First go through the MRI films and then see the report. Thank you. Any questions? Okay, now I would like to ask the next speaker.
His technique on outside in and inside out technique.
Good afternoon, everyone. So I'll be, after that wonderful talk by Dr. Ajinkya, where he described the anatomy and the types of tear, let's go to the management of these tears. Those are my affiliations. So the learning objectives would be what are the contraindications and indications to repair a meniscus, and an overview of the outside in and the inside out techniques. So why to preserve the meniscus? Several studies which highlight the effects of meniscus tears show that the contact areas are reduced between the condyles after a tear. There are increased contract stresses, decreased anteroposterior stability, and increased laxity. Now all these would lead to a faster progression to osteoarthritis if the tear is not treated or after a meniscectomy. So the indications of the repair, what are the patient factors that are favorable? So a younger patient less than 40 or an active patient more than 40 years, BMI being less than 30, and the patient to understand the maybe a long drawn physiotherapy protocol and should comply with it. The tear characteristics, the red and the red-white tears are the ideal ones to repair, more than 7 millimeters in length. the chronicity is less than 3 months, and an associated ACL reconstruction is favorable because of the bone marrow that is released in the drilling of the femoral tunnels. The types of tears which again are favorable for repair are the horizontal tears, the longitudinal tears, radial tears are potentially repairable, bucket handle tears, and the root tears. Oblique tears like the flap or parrot beak and the complex degenerative tears are usually irreparable. Contraindications to repair are existing OA of the knee, untreated instability, the white avascular zone tears, BMI more than 35, and an existing malalignment of the knee. So going to the inside-out technique, what are the indications? So these would be catered to for the posterior horn tears, middle third, bucket handle tears, peripheral capsular tears, and where meniscal allografts are being put into place. Inside-out techniques are still considered the gold standard. These, because the entry point is known but the exit point is blind, need accessory incisions, posterolateral or posteromedial, depending on which meniscus is being treated. This is just an image of that. The structures which are at risk, on the medial side, the saphenous nerve and vein. So dissection should be kept posterior to the MCL, peroneal nerve on the lateral side. So dissection should be kept between the LCL and the bicep femoris, and the popliteal neurovascular structure where there is repair of the posterior meniscal horns involved. Zone-specific cannulas and long flexible needles are generally used for these kind of repairs. Just a video of that. This first bite taken through the periphery, meniscocapsular area, the needle is being passed, and that pulls the one end of the suture. And the second bite being taken through the substance of the meniscus. There you can see the needle, and that needle is then pulled out from the capsular side, and when that is pulled together, that forms a nice knot over there. This is how it would look after the repair is complete, where one end is through the capsule, the other end is going through the meniscus, and the knots are taken on the capsular side. For the outside in technique, again, anterior horn tears is a good indication for doing this technique, and similar indications as were there for the inside out technique. The outside in technique is good because there's minimal inventory, just need a spinal needle and maybe a 2-0 or 3-0 ethylon or proline. It's safer because the starting point is known. Cannulated guides are not needed. This can reduce the risk of injury to the cartilage, and smaller skin punctures are needed to pass the knot onto the capsule. Again, a video of the same where you can see that almost red zone tear. Now here we are using the meniscal rasp to freshen the edges of the tear. This first bite from outside to in through the capsule, pulling it out through the anterior portal. Second bite through the body of the meniscus. A proline is different colors used, and then it's knotted outside and shuttled like you would do in a shoulder surgery, and the knot is taken. This is the final reconstruction where you see that 2 knots were being taken to repair it. So my take home points is repair, consider strongly in patients less than 40, tears in the red-white zone, and there's an associated ACL reconstruction. Get familiar with one technique or at least 2 techniques because literature shows that the failure rates of all are more or less similar, and what's important in these techniques is to know your safe zones. Thank you.
Any questions? Okay, sir. Sir, if you said that ACL reconstruction is preferred during a meniscus, if there is an associated ACL injury, so how does a bone marrow help in healing the meniscus?
So again, we know that, and there are various studies which have been done where we are using PRP, we are using fibrin clot, and so these the marrow that is released from the cancellous bone is said to again aid in the healing of these meniscal repairs.
So would we put a clot while repairing a meniscus? That would be more to be said that.
Yeah, but now if you're anyways doing an ACL reconstruction, obviously then you will not.
No,
but suppose if it's an isolated meniscus tear, again literature varies where it comes to using these biologics, fibrin clot and PRP. Whereas some studies have always said that, that meniscus will heal better. Some studies have said that, it doesn't make a difference. So I think we would have to largely go by what, your personal clinical experience also is with that.
Thank you, sir.
What number fiber wire do we use for meniscus?
So
or
we
tape
can,
you prefer?
yeah, sure. So we can use, generally we use a 0 fiber wire or a 2-0 fiber wire, but a 0 would be a sturdier one.
Can I have another mic, please?
Sir?
So,
Sir, please go ahead. Please go ahead.
so we all know that the patients don't come to us early. So what
You
is
mean
the
after
duration?
tear? After the tear?
Yeah, after the injury.
Yes, sir.
So what would be the safe duration beyond which, like, in which you will do the surgery, and beyond that you would go to excision?
So that's a good question. What I had mentioned, one is 3 months is a rough period, what you would say. But again, it's more about the patient's clinical symptoms, what clinical symptoms he's presenting with. Then secondly, on arthroscopy, what do you see? What the condition of the meniscus is, which area the tear is. And I think my final decision would be when I'm actually seeing the meniscus and what the condition of the meniscus and the repairability of it. So not so much so just the duration, but all these multitude of factors taken together. Also, where there's a younger patient, I would tend to take that chance with going ahead with the repair. But if someone who's more than 40, I may just go ahead with a meniscectomy.
Sorry, may I ask a question?
Please go ahead.
Yeah.
Sir,
If you see 100 meniscus tears,
sir.
out of those 100, how many do you think are truly suitable for a repair?
So going by
a percentage.
Sure. So going by what I have seen, I would say 50 to 60% is what I would tend to repair.
Thank you so much, sir. We would like to...
Aditya, last question. What is your approach for the radial tears in the body zone?
So radial tear, what I would tend to do is if that radial tear is extending up to the capsule, I would tend to do a side-to-side stitch where the red zone is there, and then the zone 3 is where I would just do a partial meniscectomy.
Thank you.
Thank you.
Thank you so much, sir. We would like to invite Dr. Bhushan Patil, sir, on his topic for all inside techniques and ramp repair.
Hello. Good afternoon, everyone. At the outset, I would like to thank organizing committee of Bombay Orthopaedic Society, WIROC. So my topic is all inside meniscus technique and ramp repair. So all inside repair is where we take the bites or they take the sutures on the torn meniscus, especially in the posterior horn, and repair. This process is all intra-articular, where there is no need to take the sutures out of the joint. There are specific indications which are posterior horn tear of the medial as well as lateral meniscus. They might be in isolation or it is with the bucket handle tear. In this picture you can see, this is the classification. This is a medial meniscus posterior horn, and this is zone is 0, 1, 2, 3. This is a red, white, red zone, then red, white, and white. So this is the area where we would like to go for all inside repair technique. And of course, with the newer cannulas and newer systems, there is an extended indication or extended. In the body also we can do all inside repair, but mainly it is on the posterior horn of the medial as well as lateral meniscus. In these images you can see there's a white arrow showing the meniscocapsular tear, and the other one is in the zone 1 and 2. So these tears are good for meniscal repairs. So as I said, as we discussed earlier, radial tear is a very challenging because it's as good as a meniscectomy, complete meniscectomy. There's a lot of forces acting in the joint after the tear, and chances that early rapid arthritis will develop. So it is better in a younger individual. It is better to go ahead with the repair, and in this, these tears can be managed with the different devices, or all standard all inside is different, because we'll see in the coming slides. So horizontal cleavage tears, especially seen along with the discoid meniscus in the younger pediatric population, and degenerative. So we tend to repair mainly discoid meniscus horizontal cleavage tears, so that this, this pediatric age population will not have arthritis later on. So there are a lot of challenges in the lateral meniscus repair. First is tight compartment. On the medial side, if the compartment is tight, then we can go ahead with the pie crusting. But on the lateral side, there are limited joint space, so you have to have good assistant which will give you figure of 4 position and open up the joint for the procedure. So next is proximity to the neurovascular bundle. So there are a lot of studies going seen in the pediatric age group. The popliteal artery behind the posterior horn of the lateral meniscus is ranging from 3 to 4 millimeters. When the adult, it is up to 6 to 8 millimeters in the from the posterior horn of the lateral meniscus, especially in the extended knee, and of course without distension. And the common parallel now also is the close proximity to the popliteus tendon. It is approximately 13 to 18 millimeters away posterolaterally to the popliteus tendon. So there are two schools of thought. One group of people said we can get a penetration through the popliteus tendon, but eventually, of course, we are damaging the popliteus tendon while doing that, but eventually it might fail because the movement of the popliteus during flexion extension. And one French surgeon says we can go ahead and fix the lateral meniscus tear through the popliteus and fix it. Yeah. So in this figure, you can see, in the picture, you can see this proximity of the popliteal artery just behind the lateral root of the peripheral part of the lateral meniscus, hardly 6 to 8 millimeters. So why it is important too is when we are doing, this is a viewing, normally this is anterolateral is a viewing portal and this is a working portal, and to avoid this we can go anteromedially, so that the trajectory of the needle would go away from the posterior horn. The steps to avoid is, again, as I earlier mentioned, figure of 4 position, to open up the joint, not only to open up the joint, but to keep the vessels away. When in flexed position, they tend to go away from the posterior horn, so that we get enough space. So this posterior 10 millimeters is the crucial zone behind which there is the proximity of the artery. Penetration has to be limited, 12 to 14 millimeters, and possibly it should be passed to the anteromedial portal, so that trajectory goes laterally away from the neurovascular bundle. So devices used are all inside technique are different. With anchor, without anchor, we can classify. So with anchor, normally what we use is there are many companies coming up, have this, there are different guns, and you should be familiar with that mechanism outside before starting the procedure. And of course, you have to consider all the points before you can have good anatomy of the posterior part. I'll just go to this radial tear. As we earlier discussed, it is challenging, and there are different configurations for the repair, hashtag or rib stop and mattress, double mattress suture. Ramp lesions are the lesions where earlier this has been described by the colleague, and these type 4 is the most common here. This is longitudinal tear in the ramp region. Sometimes there are additional bucket handle type of tears. This is the most commonly seen and is very challenging. Normally what we should do in diagnostic orthoscopy, we should put a needle from the posterior medial portal, and once the needle is inside, we have to lift up this area and check for this tear if it is there. Otherwise, this is supposed to be a hidden lesion, and most of the times it is missed. And in a chronic scenario, or when the patient comes for a revision surgery, most of the time this has not been repaired, and that can be the cause of failure of the ACL. And there are 2-3 ways. Either if it is possible, you can lift up the capsule and put all inside devices from inside the joint, or if it is not possible, some people say this is shoulder in the knee joint, because this is kind of shoulder surgery inside the posterior medial. People who have been doing PCL reconstruction arthroscopies, they are familiar with this approach and it is easy for them. So we can put a metal lasso or ramp lasso from posterior medial portal and take a bites through the capsule as well as the peripheral meniscus, and put a sliding knot to fix that. This is video. I'm sorry for this time delay. This is after this trepanation and preparation of the peripheral part. This is the cannula. This is the depth. This cannula will avoid too much of penetration there. Needle is going from the substance of the meniscus towards the periphery. And vertical mattress suture is the better pull-out strength. We avoid taking horizontal mattress suture, but sometimes there is a cost constraint. We take a horizontal mattress also. And now it is going to the periphery. and the peripheral part of the meniscus, so that we get a good compression at the tear site with the vertical mattress type of configuration. Excuse me for the delay. Yes. And once, many times what happens is after taking this sutures on the superior aspect of the meniscus, this gets elevated. So to compress that, we have to take a bite or take a fix the meniscus on the inferior part of the meniscus also, so that this elevated part should settle down later. After this, usually this ratio is 2. If we are taking 2 vertical mattress suture, there has to be minimum 1 mattress suture on the inferior portion of the meniscus, so that the ratio has to be 2 superior sutures, 1 inferior suture. And if we can take a horizontal mattress as well, if we have 3 sutures, vertical sutures, 1 here, 1 there and 1 here, we can take in between 1 horizontal mattress suture on the inferior portion of the meniscus, so that it gets compressed there. Good compression of the inferior part also, as well as this elevated part of the meniscus will settle down. So the take-home message is in all inside technique is very demanding and relatively easy procedure once we are habitual with that. But it is challenging, and considering all these precautions should be taken and limited space there on the lateral compartment. And ramp lesion is a hidden lesion, should not be missed. We should always do a diagnostic round in the posterior middle compartment by needle probing, and tears which are less than 50 millimeters in acute ACL tear can be just freshened up the edges to heal if we are doing ACL reconstruction at the same time. And chronic and revision scenario, this ramp lesion should be repaired well. Thank you so much.
Thank you, sir. I'd like to invite Dr. Nikhil Agrawal for his talk on meniscus root
Thank you.
repairs. We'll do the question answer session for this talk later on.
Very good afternoon, everyone, and thank you, WIROC organizers, for giving the opportunity. My topic is on meniscus root tears, which is generally known as the silent epidemic. Myself attached to Jagjeevan Ram Railway Hospital, Mumbai, and work hard. So, meniscus root tears is a silent epidemic. It is not as rare as once we thought, and often these tears were treated conservatively or by partial meniscectomy, which eventually led to progressive arthritis. And 10 to 21% of all these meniscus tears are meniscus root tears, and they're often missed in the clinic as well as on the MRI. Laprade has given a good classification of the root tears and has defined it as a soft tissue avulsion or a bony root avulsion, or tears which are located within 1 centimeter from the meniscus root attachment. Out of these, the most common is a type 2, that is a radial tear within the 1 centimeter, comprising of almost 70% of the root tears, followed by type 4. So these are the radial meniscus root tear, how they look intraoperatively. They are within 1 centimeter of the root, and the loading patterns are similar to the root avulsions. And sometimes these tears often is reported to be 28% of the overall meniscal tears in some series. If the root tears go untreated, they lead to eventually rapid progress to OA. They are biomechanically compared to total meniscectomy, it leading to the comprised hoop stresses of the menisci, which increases the pressure between the tibia and the femoral pressures, and eventually degeneration of the cartilage. So this you can see how after the tear, the contact pressures in the tibiofemoral joint increases with this scanning studies. This is a typical history of a meniscus root tear which goes untreated and leading to rapid degeneration of the cartilage, and within 24 months the patient lands into a UKR. So a lot of good talk has been given by my friend regarding the anatomy. Just to highlight, the middle meniscus posterior root is very adjacent to the PCL, and the lateral meniscus is about 1 millimeter posterior to the lateral tibial eminence. It's very important that the anatomic footprint is restored during the reconstruction to give the best of the result. This is a typical patient of a middle meniscus posterior root tear presenting in the clinic. They are generally a middle-aged women or men, more commonly in the females of 40 to 60 years age. It may be an acute or a chronic presentation. Generally, they are on a heavier side. They are mostly the degenerative type of tears, and there is no significant trauma or injury they undergo. In 70% of the cases, it is without any significant injury. However, associated in 3% of multi-ligament injuries. So generally, these patients come to with a history of a very trivial injury or a jerk while climbing down from stairs or while stepping down from the bus, and they present to us with very sudden onset of very severe pain, limping with pain, and also give a history of audible pop sound at times. So on examination, when you see in the clinic, there is severe tenderness, very positive McMurray test. On flexion, they wince with pain, and extremely minimal to moderate decrease in the joint space you will see when you do the standing X-rays. And please do order MRI, and you can see appreciate the ghost sign, which is represents a posterior root tear. This is how the MRI picture looks in the sagittal, axial, and the coronal images. You see the ghost sign in the sagittal image, a radial pattern in the axial image, and a truncation pattern or a severe extrusion you can see in the coronal image. The medial posterior root tears are easily diagnosed on MRI than the lateral meniscal root tears. So this is how a patient, 54 male, patient pain in the knee since 1 year. It was an old neglected posterior case of a posterior meniscus root tear case who developed into a sponk lesion, spontaneous osteonecrosis, and with a loose fragment. So this can happen if you neglect the root tear. The lateral meniscus posterior root tears comparatively happens in young patients. It's mostly because of trauma. Mostly they are males, and 10.8 times more commonly associated with the ACL tears than the middle meniscal root tears. And remember, 12% of all the ACL tear will have lateral meniscal root tears, and we should always probe the lateral root because they are missed on MRI. In the ACL reconstructed knee, a tear of the lateral meniscus posterior root significantly increase the knee laxity under anterior loading as much as 1 millimeter. So they contribute to the ACL stability as well. So they must be repaired at the time of your ACL reconstruction. So what is the treatment of these root tears? Non-operative should be considered in elderly patients who have very severe arthritis, or they are asymptomatic chronic tears. You can conserve them. And if you will land up in partial meniscectomy, they will have early good results, but later on they will soon develop severe degeneration. And arthroscopy root repair is the best clinical outcome what we can have in the current era. So what are the indications? Always traumatic cases, acute presentation, you always repair them. And in the degenerative cases, the indications are still evolving. However, the contraindication is severe collapse, severe varus, significant arthritis, or a BMI more than 30. So this is the gold standard technique, that is the anatomic transportal transtibial pull-out suture technique. And these are the two most common used instruments, is the knee scorpion and the meniscus root repair jig, which you should have while doing this technique. Also, suture anchors have been described, suture root anchor repair techniques. And this is how you start with the diagnostic scopy. You often find the middle compartment is tight since these are degenerative knees. You have to do a pie crusting of the MCL and a reverse notchplasty to gain more access to the posterior root. And then the gap opens and you can identify the posterior root. So these are a few steps. You take a bite with the knee scorpion with few threads and take at least 2 sutures in the cinch type of fashion. Prepare the bed and drill the tunnel and shuttle the tunnel and get the fiber tapes or the suture fibers on the anteromiddle aspect of the tibia and get a good repair. This is the video of the same. You do a pie crusting, identify the posterior root. Often these old tears are attached to the posterior capsule. Go ahead and release them, and then prepare the bed where the attachment is with a sharp curate till the subchondral bone is there. Take a bite with a suture fiber or a suture tape if you like in the root with the help of the knee scorpion coming from the anteromiddle portal. You can have different type of suture configurations. This is my choice for the root repair. Have 2, you can also have 3. And then you drill a tunnel with the help of the meniscus root repair jig, which is specially designed for this technique. And this tunnel starts from the anteromiddle aspect of the tibia, a little bit away from the tibial ACL tunnel. Sometimes you have to combine this root repair technique with the HTO if you have a varus alignment. And the rehab after this, you should remember, is non-weight bearing. You have to keep this patient for at least 6 weeks. Range of movement should be restricted up to 90 degrees for the first 2 weeks. And no leg press exercise or no squatting beyond 90 degrees for 4 months. So the results are extremely good. The root repair technique restores the joint contact pressures. All the meta-analysis and systematic reviews have reported significant improvement in both functional and the subjective objective scores. And there is significant lower rate of progression of OA and conversion to TKR as reported by this paper at 5 years follow-up. So definitely it should be, these root repairs must be looked upon. This is a patient preoperatively wincing with pain and cannot walk. And now just after 2 months, she has a very good gait. However, one lingering issue of this root repair technique is the phenomena of post-operative meniscus extrusion which is there. And more work is needed whether to decide or confirm whether the centralizing suture what we take to repair this extrusion really is beneficial or not in the long term. To summarize, early identification of these patients with degenerative middle meniscal root tear is very, very important in your clinic. Most often we miss them and treat them as OA knees. We do not advise any MRI. So my message would be advise MRI to these middle-aged women or men who come to your clinic with severe pain. And during arthroscopy, the message to the surgeons is to probe every root which is there, and most of the time with ACL tear, you'll have your lateral meniscal root tears. And arthroscopy root repair surgery is a revolutionary surgery to bail us out from this silent epidemic of arthritis because of these tears. Thank you.
Thank you, sir, for your talk. I'd like to invite Dr. Deepak Tambe for his talk on discoid meniscus, affordable in meniscal implants, and improved repair techniques.
Good afternoon. Thank you all the organizers, Dr. Abhijit Kale sir, Dr. Ashish Fadnis sir, and Bombay Orthopaedic Society for inviting me. I am Dr. Deepak Tambe. I will start the session with the learning objectives for discoid meniscus, obviously the diagnosis, the clinical features of the discoid meniscus, classification, and what do we do as a surgery for the discoid meniscus. So what does it, how does it present? It is a asymptomatic problem. Patient can have a snap or clunk without pain, which may not require any treatment, but snapping with the pain and locking will definitely require to do some intervention. Knee extensor lag can be there. Usually the incidence is around 2 to 5%. Lateral meniscus is more commonly involved, and always look for the other knee because 15 to 20% of the patients are bilateral. So what do we see on X-ray of these patients? So there is an increased lateral joint space. You can see hypoplastic lateral femoral condyle. The tibial plateau on the lateral side, which usually is convex, can be flattened, and tibial spine on that side can be blunted. So these are all telltale signs of discoid meniscus, which are seen on digital X-ray. As you see on MRI, there can be a bow tie sign, and the meniscus occupies almost more than 15% of the area of the lateral tibial space. As you go on parasagittal sections, there also you can see that the bow tie sign and the meniscus is occupying almost the entire width of the knee joint. The meniscus to the tibial condyle ratio can also be very high, more than 15 millimeter it can be there. So this is on MRI. Usually we classify them as a complete, incomplete, and Risberg type of discoid meniscus, lateral meniscus. While in first two cases we have a definite attachment peripherally, incomplete and incomplete type. Complete means it occupies the entire lateral joint. While in third type, Risberg type is little unstable and it doesn't have a peripheral attachment. Only to the Risberg ligament you can see the attachment. So when you scope all these patients, you can find some fat pad in between the ACL and discoid meniscus. You need to debride the fat pad clearly, and this is type 1 lateral discoid, which you can see that it is extending right up to the ACL. You can see the over surface of the discoid meniscus, the under surface. Start resecting the meniscus from the anteromedial portal. You may need to change the portal, working portal, to anterolateral portal. You should be having right and left arthroscopy punches as well. It will save time. Routinely debride the fat pad, infrapatellar fat pad, to get the vision properly. See the attachment peripherally onto the under surface of the meniscus as well as to the over surface of the meniscus. This is the popliteal tendon. This is quite stable meniscus, so go ahead with further debridement to make it a saucer-shaped meniscus looking as normal as possible. This is what I mentioned, that you may need to shift your portal to the working portal to the anterolateral portal and debride the meniscus properly. Now we are resecting and reshaping the meniscus to make it as normal as possible. So what is the end point of all these things? As soon as your clunk is gone on range of motion, if it is not gone, then either you need to further resect the meniscus. This is the tear which has been found in the lateral meniscus. Obviously the patient presented with clunk as well as pain, so he must be having some pathology into the meniscus substance. So either you need to stabilize that patient or resect it more till the time you do not get clunk on range of motion intraoperatively. So this can be little confusing. This is the bucket portion, handle portion of the bucket handle tear, and it is retracted and not reducing properly. So don't confuse this with the discoid meniscus. So resection and repair is the surgery which we will do for the discoid meniscus, and the end point is on range of motion there should not be any clunk. So you have to repair those. Rarely replacement or transplant may be required for the discoid meniscus. So the patients mostly are asymptomatic. They may have snapping which will not require any treatment. MRI is the most sensitive diagnosis. Check for the other knee. Most commonly resection and repair or saucerization and stabilization is what is required. You can see in the hall there are a lot of young arthroscopy surgeons, and most of them are from the medical college. Now most of them must be facing this problem that all inside repair which we have shown is little costly. The implants are very costly. So let me go through my techniques. Usually what inventory you require. Do you have ETO sterilizer at your institute or medical college? And MCL tenotomy, do we require it in all the patients? So inventory 2-0 fiber wire, most of the Indian and all standard companies also have 2-0 as well as the tape. These are the three instruments, 2-0 mini suture passing devices. They come in disposable as well as autoclavable instrument. 2-0 knot pusher as Sir Bhushan sir shown with the cutter, and inside out needles with net-on loop. All the companies do have this. You can ask your friend to either or any company person to supply that which has already been used, and you can make them ETO sterilize at your institute. So this is what I prefer to do in my initial days, MCL tenotomy, even for the medial meniscus resection, and that is how you increase the lateral joint space after MCL tenotomy till you get the grade 2 MCL laxity. That is it, and that is how you go ahead with the repair technique. So this is a tear along with the cyst, and that is how you probe that tear. You debride that tear usually with the meniscus probe. This is the routine probe, but with the meniscus probe you debride it, make it rough, and then you can make use of a disposable instrument, 2-0 mini suture passing devices. Actually it is to be used only once, but you can make it ETO sterilize and use it for 2-3 cases. That is the 2-0 fiber wire going, and that is the 2-0 knot pusher along with the cutter. That is also a disposable instrument, but you can hire it from your colleague and make it ETO sterilize. That is how you take a knot with the same knot pusher and cut the knot. Similarly, you can take multiple stitches, as Bhushan sir have already told, that 2:1 suture, 1 above and 2 below, so that the meniscus is kept balanced and it is not everted or inverted anyhow. Finally, you check whether it is stable meniscus repair or not. Similarly, this we have already seen. This is also a standard needle which you can use it for the meniscus repair from inside out technique. This is also a disposable one, but you can use it as per your want for another 2-3 cases to make it affordable. So take home message, tenotomy, I would like to prefer it in most of the patients so that medial joint space is increased and my meniscus repair or root repair becomes very easy, even for few cases of meniscectomy. And if it is available, ETO sterilizer, you should always make use of that to make it as affording as possible. So thank you very much for that.
Thank you so much, sir. It's a wonderful presentation. May I ask the house if anyone has a question for all the presenters?
Discoid meniscus, after you resect it, will you always do you always repair it, or you can leave these tears in the discoid meniscus? Can you leave them also alone?
See, as far as possible, if it is stable resection and saucerization, we'll leave it like that. But most of the cases, you will find a tear definitely which needs repair.
How much you will keep the peripheral portion, the remaining portion? And what is your criteria to fix this horizontal cleavage which is remain there, stabilize the horizontal cleavage?
So horizontal cleavage has to be repaired. There is no other option. 15 millimeters of meniscus. Till you can see that it is normally occupying the joint space, you have to keep it like that.
So, Dr. Nikhil, I'd like to ask you. So, where your root repair, your talk was wonderful. So, which are the root repairs which you will leave alone? So, say on arthroscopy, you see them and you leave them alone.
Generally, these the anterior root tears, we can leave them alone. We can just shave it off and no need to repair. And the posterior root tears, if it is a chronic degenerative with severe arthritis, then you just shave it. But definitely for young population, you should repair all your roots.
One more question, sir. You said that you use fiber tapes also and fiber wires also. So
I use to suture the fiber wires only, but there is an option. People do use suture tapes also now with different configuration.
What number of tape would you?
I am not using a suture tape, so I'm just because that exactly because the firing device which we have is suitable for the suture the fiber wire, not the tape.
Not the tapes.
But yes, tape is an option. You can shuttle it, and in that method you can do it.
Okay.
1.3 mm suture tape you can just pierce.
Yeah. So the option is there to use a tape.
Thank you so much.
My question to Dr. Nikhil, you have a wonderful presentation. So I'm Dr. Shomodi from Kolkata. So sometimes this root repair, after repairing in a long follow-up, you see these roots are not healing. Do you have any such problem?
We have not done any MRI study or something because long-term studies you will require this. Definitely the junction of the meniscus to the bone, that is maybe that the healing can be an issue, but clinically these patients do very well.
Yes.
I think Dr. Roshan can add to it.
How long it takes for the symptoms to settle down?
Symptoms actually, these acute degenerative, acute tears when they come with a severe pop, 1 month, 2 months duration, they do very well once you repair. As I showed that patient walking, they're very happy immediately in the next 3 to 4 weeks and they do well.
And any other
The pain goes well.
besides the suture weave, a screw or anything?
Anchor, suture anchor is there, described very well, one of our friend Dr. Pratmesh Jain about the root fix anchor it is called, a soft tissue, a soft anchor.
Scorpion and a drill hole.
Sorry?
Then you don't need a
They have the different technique, very minimal drilling is required in that to pull out your suture anchor in the tunnel. But the anchor remains there, the attachment is closer to the tear. So that's why they say that it is a better technique, but still not yet proven.
How often do we need to chop off a little bit of a tibial spine to get access?
Yeah, so it all depends how your access is. Sometimes the tibial spine is prominent, so you have to shave that tibial spine off. So there is no worry of doing that with a burr, as I showed in that technique.
Nikhil, yeah, Dr. Roshan, go ahead.
Yeah, Roshan can
regarding the
highlight.
question which Dr. Samadip asked, and what are the tears you leave? As I think somebody was discussing. So there are multiple studies whether the root tear really heals or doesn't heal. There are n number of techniques which are described. But I feel the root avulsion technique which you showed was the commonest one which is performed, and the maximum non-healing rates is with the same technique. So we don't know what exactly is the reason why. But the most important thing in any root repair, and the one most important key message everybody in this room should carry, is correction of alignment. So unless you have a normal alignment, your root repair is day one failure.
Yeah.
So unless you have a perfectly normal valgus alignment, even a 5-degree varus or 4-degree varus or 3-degree, which is normal varus as far as the knee replacement is concerned, is pathological when you have a root tear. So unless you have a valgus alignment, your root repair is going to fail.
Right. Malalignment is a cornerstone.
Yeah, one question, Dr. Roshan, and of course Dr. Nikhil. The type 2C, it is 10 millimeters away from the attachment of the root. And then we say, suppose sometimes it is too medial, this tunnel is too medial, then we say it is not anatomical. But actually the tear is away from this center point of the fixation of the posterior horn. And then still we say it is non-anatomic. So is there any need actually to get to this root? Because actually tear is not there. Still we try to tend to get this too lateral towards the point.
So I'll go in historical aspect. The root repair, which is described by Dr. Rob Laprade in year 2011 or 12 rather. But the original root repair description came from India, Dr. Nicholas Antaw. Nicholas Antaw published in year 1996 in IJO, where he, same question, what he asked, the root tear away from the attachment of the root, say 5 millimeter away from the attachment of the root to 10 millimeter away from the attachment of the root, and he described it as a posteromedial fiber tear. That time people neglected that paper. But if you study the Rob Laprade's original article and Dr. Nicholas Antaw's description of root tear and posteromedial meniscal tear, they are similar. The issue was always same. Now coming back to the management factor, if you try to pull that root back to the natural thing, you are distorting the anatomy of meniscus because there is a loss of meniscus when you are considering it. So once you have a loss of meniscus and you try to pull it, you are making patient worse. In that situation, best is to debride the root, do only the alignment correction and forget about it.
I'd like to ask you a question, sir. In your root repairs, do you do a medial release to bring the root back to the insertion, as Dr. Laprade has described?
Yeah, in certain chronic stages when the root is attached to the capsule, you have to do the release, as shown in that video. But yeah, it's always a challenge what Bhushan has mentioned. We find the tears to be more medial and we still have to find a perfect answer for it.
Thank you, sir. Thank you so much. Thank you, everyone. It was a wonderful session. And thank you, sirs, for being a convener. And thank you, the participants. And thank you for wonderful questions.